I'm going to talk about tobacco use and the risk of COVID-19, mainly focusing on diagnosis. Professor Toumbis is going to talk about the risk of severity of COVID-19. It's a bit of a mixed findings. It would be too much to present everything in one presentation, but I think it's quite interesting. First of all, we know that smoking increases by far the risk for respiratory infections. I have several data here for pneumococcal infections, but the same thing is happening also with viral infections. The risk is much higher when someone is smoking. It also depends on the amount of cigarette consumed daily. And of course, we see a decline when people quit smoking, although again, it takes a long time since quitting in order for the risk to decline considerably. So we were expecting, and that was the original communication last year during spring 2020, that smoking or even other types of inhalable products like vaping would increase the risk for developing COVID or the risk of severity of COVID and complications related to COVID-19. But our original and my original findings when I analyzed some studies, case series basically coming from China, what was, I would say impressive, paradoxically impressive, was the very low proportion of smokers who were hospitalized for COVID-19. And these were all studies coming from China. And we know that China is a country with a very high prevalence of smoking. It's about 30% in the whole population, but it's very high among males and very low among females. So more than 50, 60% in some age groups of males smoke in China. You know, there are about 1/3 of the world smokers are Chinese. So you understand that smoking is quite a tradition there. But the proportion of those hospitalized with COVID who were smokers was quite low when you compare that to the population smoking prevalent. And we went even further and we measured the prevalence odds ratio, which is basically a comparison between the gender and age adjusted smoking prevalence in the population and the smoking prevalence among hospitalized COVID patients. And it was quite low. Basically, what it says is that about 1/4 of the expected proportion of hospitalized patients were smokers. We were expecting 4 times more smokers to be hospitalized for COVID. And that was quite impressive. But that's not only our finding. There are several other studies, for example, here in Israel, an analysis of the largest social insurance in Israel, public social insurance, which measured basically the risk of being diagnosed with COVID. And they found that current smokers were about 50% less likely to be diagnosed with COVID, which is pretty unexpected because you would expect these people to be at higher risk. And not only there, in the UK, another very large data set of, I think it was 8 million people. And what they found was that heavy smokers, especially, were less likely to be diagnosed with COVID. And in that study, they were also less likely to be admitted to an ICU because of COVID. But I think that a large part of that was because they were not diagnosed with COVID. Another study, once again, now from, if I remember well, from Germany, from Essen, the town of Essen. They also found that people who smoke more than 10 cigarettes per day were 72% less likely to be diagnosed with COVID. So we're not talking about severity of the disease once they develop COVID, but it's about diagnosis. In Korea, the same thing, a lower risk of being, this is Chile. In Chile, they did an analysis of seroconversion among healthcare professionals. And they found that smokers were less likely to have developed over time antibodies for SARS-CoV-2, which means that they were infected and they were seroconverted. This is from Korea, which once again showed a lower risk for SARS-CoV-2 infection among smokers compared with non-smokers. So, we went further, and we published studies of 20, and in some cases more than 30 different studies and meta-analysis, and we were still finding this under-representation of smokers among hospitalized patients. So much lower proportion of hospitalized smokers of hospitalized COVID patients were smokers compared to the population smoking prevalence, even when you adjust that by gender and age, because we know that older people, in older people, the smoking prevalence goes down. But does it mean that smoking is protective? Of course, it doesn't mean that smoking is protective, and you can never use smoking for any kind of preventive or protective role for any kind of disease, because we all know the very adverse effects of smoking. But what does it tell us? Is there any useful conclusions if those findings are the case? Because let's not forget that all these studies have limitations. And one of the limitations is that during a pandemic, you can't focus on one marker or one risk factor alone, so you cannot have a perfect recording of the smoking status. So without forgetting the limitations, even if we assume that all these findings are pretty accurate, then there is the issue of what to do with these findings. Well, what we did with these findings is we created the hypothesis that something is happening with nicotine that may be protective. And of course, that doesn't again mean that we should use smoking, but there are pharmaceutical products, and not only nicotine, but cholinergic agonists in general, which may have a therapeutic value. So when we analyze the structure and the amino acid sequence of the spike protein, we found an area which is within the receptor binding domain, but next to the receptor binding motif, that looks very much like snake venom neurotoxin, and in terms of the amino acid sequence. And we know very well that snake venom toxins bind to nicotinic acetylcholine receptors, and they compromise, they have an antagonistic effect on nicotinic acetylcholine receptors. So we went further and did some molecular docking and modeling studies, and we found that it is possible for the virus to interact in that area with the nicotinic acetylcholine receptors. Of course, these are experimental computational models. They are not clinical or even in vitro preclinical studies, but we created the hypothesis that there may be an implication of the cholinergic anti-inflammatory pathway. This is an anti-inflammatory pathway that was discovered in 2000. There are several publications in Nature and other big journals, basically by Kevin Tracy and his group in the US, which is a pathway that controls and provides immune homeostasis, so it can up or down regulate the immune response in order to have a certain balance through a central mechanism using vagus nerve through the brain, and by using alpha-7 cholinergic receptors, which are available everywhere in the human body, I mean literally everywhere, including in immune cells, including in epithelial cells, bronchial epithelial cells, everywhere. So this is a mechanism through which the immune response can be balanced. And since we know that COVID-19, and especially the severe form of the disease, is basically a sort of a form of cytokine storm, a sort of hyperinflammation and an imbalance and a dysregulation of the immune response, we made the scientific hypothesis that there may be something wrong with the nicotinic cholinergic, the cholinergic anti-inflammatory pathway through the action of the virus on the alpha-7 cholinergic receptors, and this creates that sort of an imbalance. And by protecting the alpha-7 receptors and restoring the function of the cholinergic anti-inflammatory pathway, we may see an improvement. And we did some additional molecular modeling studies, and we also analyzed not only nicotine, but other cholinergic agonists, including varenicline, for example, which is a smoking cessation medication. And we found that there may be some interactions on a computational models between these compounds protecting the alpha-7 cholinergic receptor when compromised by the virus. And what happened recently, a couple of months ago, is that our scientific hypothesis was verified in vitro and in vivo in monkeys, in experimental animals, using two alpha-7 cholinergic agonists. One is indeed varenicline, and another one is a proprietary alpha-7 cholinergic agonist by this company, which is a pharmaceutical company in the US. They did in vitro studies in bronchial cells and in vivo studies in monkeys, and they found that the viral load is reduced significantly when these compounds administered compared to placebo. So it is quite an interesting hypothesis, which is still evolving, of course. And I know, since we are in contact with the company, they contacted us, that they want to proceed with a clinical evaluation of this hypothesis. So in conclusion, the data with the limitations, and there are several limitations, show that smokers seem to be less likely to be diagnosed with COVID-19, and fewer smokers than expected appear to be hospitalized for COVID. But I'm sure, as Professor Toumbis will show, and we've also published that once hospitalized, smokers have a much higher risk of developing severe COVID-19 or even dying. This is also our finding. So there is some sort of a mismatch between being diagnosed and then having severe COVID. These findings, of course, do not support any role for smoking, but they do support the hypothesis of pharmaceutical intervention in relation to cholinergic agonists, which, of course, we don't know yet if it is clinically valid. So we need to wait for clinical studies in order to verify our hypothesis. So that's my presentation. Thank you very much.